Well, did your doctor tell you you needed a total abdominal hysterectomy and you weren't quite sure what that entailed or why you couldn't get another type of hysterectomy? Well, today I'm going to talk about the total abdominal hysterectomy, what it is, and why do we do it. That sounds good to you? Continue watching. Well, welcome back to my channel. I'm Dr. DuPont. I'm a board-certified gynecologic oncologist, and I'm passionate about educating women on how to improve their lives, and I believe that begins with great health. Well, today we're going to talk about a very common procedure called the total abdominal hysterectomy. Well, when we're thinking about a total abdominal hysterectomy, and I'm going to shorten it and say TAH or abdominal hysterectomy, what that is just removing the uterus. So this is my cute little uterus the patient gave me. The top of the uterus is called the fundus, and the base of the uterus is called the cervix. Most of the time when we're doing a total abdominal hysterectomy, we're removing the uterus and the cervix. And typically that's through an open incision. So that's why it's an abdominal hysterectomy and not a vaginal hysterectomy or a laparoscopic hysterectomy or even a robotic hysterectomy. So total abdominal hysterectomy is just removing the uterus and cervix. Now, if we remove the fallopian tubes and ovaries, so this is the tube and these are the ovaries, then that doesn't change the hysterectomy. The hysterectomy is only removing kind of the womb, the uterus and cervix. We may leave the ovaries in a woman that's young because we do know it still makes hormones that will help delay the time she goes into menopause. We may or may not take the tube. So a lot of times now when women are done having their children and they want a tubal ligation, we're actually now doing removal of the complete tube, so a salpingectomy, so that we can reduce the risk of ovarian cancer in the future. But it also prevents future pregnancies. Whether the ovaries or tubes are removed is separate when we're talking about a hysterectomy. So now that we got that out the way, some other terminology I want you to know is some people will say, am I having a subtotal or supracervical hysterectomy? So another terminology, it's not really a doctor term. A subtotal just means we're going to take the fundus and keep the cervix. So the cervix will stay and the fundus is out. Now, it was popular a while, maybe 10, 15 years ago, but it's not as popular nowadays. Typically, if we're doing a hysterectomy, we're going to remove the uterus and the cervix. People thought that if they kept the cervix, then sexual function was retained, or if they kept the cervix, then the risk of pelvic organ prolapse was diminished. Well, studies have shown that that's not the case. So typically we do try to take the uterus and the cervix. And if we're doing a traditional laparoscopic hysterectomy, in order to get the uterus and cervix out, we usually bring it through the vagina, where in the past, if they were doing a supracervical hysterectomy, they would keep the cervix, take the fundus, and then morcellate it, where they kind of chopped it up in a bag and then took it out through small incisions. Well, we don't typically do that anymore, and so we do try to take the uterus and the cervix, if at all possible. Now, there have been some instances where I've done a supracervical hysterectomy. The most common is mainly for cancer. So let's say there's so much cancer, I can't safely get the cervix out, then I will leave it. I remember several years ago, I had a colon cancer patient who actually had colon cancer, but it had metastasized or spread to her uterus. And her case was just very difficult. And I wasn't able to get the complete cervix out. I was able to get the uterus out without trouble. And that's where the cancer was, the fundus part or the top of the uterus. But the cervix was almost like cement. I could not get it out. And then there also be cases of people with stage 4 endometriosis or very severe endometriosis, where the endometriosis could be attaching the lower part of the uterus to the area that's close by the bladder. And so a lot of times to prevent bladder injury, we may retain the cervix and do a supracervical or subtotal hysterectomy. But for most women, we do prefer to take the uterus and cervix out. It also reduces the risk of them having to have pap tests and getting cancer of the cervix because their cervix has been removed. Now, keep in mind that if your cervix is retained for whatever reason, whether it's bleeding or endometriosis, or you just ask that it be retained, you can have bleeding, mainly if your ovaries are left in, because there's a little bit of that endometrium or the lining of the uterus that's at the top of the cervix, and that may not have been removed. A lot of times we'll try to remove it or cauterize it, but I've had a few women over the years that have had bleeding, cyclic bleeding, especially if their ovaries retained, because even though they don't have the top part of the uterus, the bottom part of the uterus can still be responsive to the hormones that ovaries are making. So unless your ovaries were removed, you can't have pretty much a cycle every month. It's not very common, but it does happen. So about 5 to 20% of the women who retain their cervix will have cyclic bleeding. So just keep that in mind if you ask the doctor to keep your cervix. Now, when we're doing a total abdominal hysterectomy, a lot of times when I'm doing it, it's because a patient has a big pelvic mass or a big tumor. And whether that's a cancer or a big fibroid or even a big ovarian mass, a lot of times those really big masses, especially if we're concerned about cancer, we don't want to spill the contents of the ovarian mass, or we don't want to morcellate it where we kind of chop it up in little pieces. A lot of those really big masses we just can't remove through small incisions. So usually the uterine size or anatomy is one of the reasons why we'll do an open or total abdominal hysterectomy, because the masses are too big. Now, the type of incision we do for an abdominal hysterectomy will vary. Depends on, what the surgery is being done for, the anatomy of the patient, and also the patient's body habitus. So if I have someone that's really super thin and I have a big mass that I'm not concerned it's cancer, I may try to do a fan and still or transverse incision. And that's more like a C-section type of bikini incision, where if I have someone I'm worried about bleeding, I'm worried about there being cancer, or if I need to see the upper abdomen, then for those patients, I'll do a traditional midline incision. And those are the ones you kind of are familiar with when you have a big cancer operation, is a vertical or midline incision. Now, depending on the type of incision will kind of depend on what kind of exposure we have in terms of visualization. So sometimes I'll tell patients, I'm not quite sure if I have to do a midline or if I can get away with a transverse or fantasil incision. It'll really depend on, when I'm examining you before surgery, how mobile that mass is. Because if it's stuck and I'm worried about injury to the bowel or cancer, then of course I'm going to do a midline incision. That gives me the best visualization to see the upper abdomen. If I have to do a lymph node dissection, it gives me the best opportunity to be able to do that because I can see a lot better with a midline or vertical incision. So we've talked about hysterectomy, kind of why we do them. And so typically what happens is your doctor will see you in the office and tell you, why they think you should have surgery. They will discuss kind of the risk and benefits of surgeries and some of the alternatives. You may need perioperative clearance by your cardiologist, depending on your health status and what other risk factors you have, because what we're trying to do is lower your risk for having complications after surgery, because no matter what surgery, there's risk to everything that we do. After you've seen your doctor, you've discussed the surgery, you've gone over the consent form. A lot of times you'll be seeing at the hospital or surgery center before surgery, where you'll meet the nursing staff. You may meet someone from the anesthesia team, where they'll talk to you kind of about their portions of the procedure. And then you may get some preoperative testing. You may get an EKG, you may get some lab work. It'll definitely depend on your age and your health status. And then the day of surgery, we typically like you to come early. Typically, the nurse will tell you to come, 1.5 to 2 hours before the procedure, because typically the start time you're given is the time we want to be in the operating room. So it's not the time you want to show up. It's the time that we want to be in the room starting the procedure. After the procedure, the doctor will send your specimens to pathology for review to make sure there's no cancer or abnormal findings. And then also the doctor will usually talk to your family member about some of the findings. And then usually for abdominal hysterectomy, you do stay 1 to 2 nights in the hospital, and that'll depend on your age, the type of surgery, and the extent of the surgery. So let's say, you had cancer, you may be in the hospital for longer than someone that maybe just had a benign fibroid or benign ovarian cyst. But typically, the total abdominal hysterectomy is a surgery where you do stay in the hospital for several days to recover. Nowadays, we do what's called early recovery after surgery, or ERAS, and I'll put a link in the description below to their website. They have a lot of good information about how we try to reduce postoperative complications in terms of getting patients up and out of bed and moving, having patients eat food sooner than we used to when I was early in my training. So those are ways we reduce risk. They'll talk about, how we reduce risk of blood clots. You may have some compression devices on your legs that help circulate them. Some patients love them, some patients don't. And then you may or may not be given a blood thinner after surgery, depending on how long your surgery was and what was the reason for your surgery. So after that, once you're ready to go home, the nurses will kind of go over some simple discharge instructions. And I will put in the link below a copy of my hysterectomy discharge instructions that I give my patients. So if you're interested in kind of knowing what I tell my patients, you can have that. It's a free download for you. And I usually will give that to patients on the day that they're going to be released from the hospital. Typically, after surgery, your doctor will see you in the office 1 or 2 weeks later to look at your incision, to go over the pathology report, and just to see how you're doing in general. Now, in terms of pain control, a lot of times now we'll send you home with a few narcotic pain pills, but we'll also have you use, nonsteroidals or Motrin or Tylenol, depending on your health history. And so you can use non-narcotic pain medicines to help your pain. Of course, we don't want you to suffer. We want you to be comfortable so that you're up and moving. But just keep in mind that after surgery, the doctor or the nurse will go over what are some common medications that you can take that are over the counter. I do know I tell patients to try Gas X because a lot of times you'll have gas pain. I've had my patients actually start a stool softener before surgery, started then actually doing stool softeners a week before surgery because I find so many women are constipated, and then the pain medicine we give you causes constipation. Some of the anesthetics that we give you for surgery cause constipation. And I've had several patients over the years that just are so severely constipated that, they may not go for a week or two. So I will tell patients to start stool softeners about a week before surgery. And I personally like my patients to take a pre and just because I do think it does help with the GI function and the immune health functioning. Now, in terms of quality of life after surgery, now it'll depend on why you're having surgery. Certainly, if you have a big tumor or a big cancer, your quality of life does improve once you've had your surgery. And studies have shown that overall, most women do have an improved quality of life after hysterectomy, but that's because they had some reason for the hysterectomy. Either they were in severe pain or they had a big pelvic mass that was causing symptoms. So for those women, once that big mass or whatever was causing their pain was treated, they feel better. Now, in terms of sexual function, most women, not all, but most women will actually have improved sexual function. And again, those are patients that had severe pain or problems before, which led to the reason for them having a hysterectomy. But there will be some women that do have diminished sexual function. So definitely talk with your provider about, the type of surgery that you're having, and then what are some of the complications in terms of sexual function after a hysterectomy. And then some of the things that we want you to watch out for in terms of some of the other complications of a hysterectomy are infection. We want to make sure you clean your incision, keep it clean and dry. I usually will tell patients to use Dial antibacterial soap or Hibiclens. Typically, most hospitals in the US, the nurses in your pre-op visit will give you kind of either chlorhexidine soap or some wipes to clean your abdomen with. And those are very good if you have some left over to use after surgery as well. You can also get the chlorhexidine or Hibiclens at the grocery store. Most grocery stores have it, or you can also get it on Amazon. And that helps reduce your risk of wound infections. Now, because the open hysterectomy has larger incisions, you're more risk to have complications from no incisions. So hernias can also happen, and a hernia is just where the wall is weak. So, patients that smoke, patients that have COPD or any kind of respiratory problems where you're coughing a lot, you put stress or strain on those sutures every time you cough. So we definitely talk to patients, try to, stop smoking 6 to 8 weeks before surgery if you can. Ideally, we don't want you to smoke at all, but definitely make sure that if you have any respiratory issues, those are dealt with before surgery so that you don't have a risk of getting, or having a higher risk than normal of having a hernia formation or even a dehiscence where your sutures break open. And so that is a surgical emergency if it were to happen. Other types of infection are bladder infections, pneumonias. So those are other things that we want, you to be aware of. And the more you're up and walking, the sooner you are active, the fewer complications you'll experience. Other types of infections are hematomas, where you're having bleeding, abscesses, infections in the pelvic area. You can get blood clots either in your lungs or in your legs. Typically, in our cancer patients, we send them home with a blood thinner for up to 4 weeks after surgery. But in all patients, we want them up and out of bed quickly because we know that the more you move around, the decreased risk you'll have for having a blood clot in your leg, and then also a blood clot in your lung, which is a pulmonary embolism. If you have shortness of breath or chest pain, definitely let your healthcare provider know or go back to the hospital. You can get heart attacks after surgery. You can get pneumonia. So there's lots of things that can happen after surgery that, if something doesn't sound right or feel right, definitely let your healthcare provider know. But most women do very well after surgery. Usually there's a reason for the surgery, so we don't just do it just to do it. So that also is very important to know that, there is always a reason for the hysterectomy. We don't just do it. So then after surgery, typically you'll see your doctor again 1 to 2 weeks. Typically that's to go over the pathology, look at your incisions. And then the second postoperative visit is to look at the top of the vagina or the vaginal cuff to make sure those sutures are healing well and there's no signs of infection. Certainly if you're someone that has bacterial vaginosis very often, you are at risk for getting a vaginal cuff infection. So those are things that I think the pre and probiotics will help reduce the risk of, and then a healthy diet. So that's all I have for you today. I have several videos on hysterectomies, different types of hysterectomies, and causes of abnormal bleeding, which usually leads to hysterectomy. So if you're interested, definitely check out those videos. I think you'll find some good information. Well, thank you for watching to the very, very end, and I will see you next time. Thank you. Bye-bye.